Okay, so good morning, everyone. We will be talking about PCL injury. So our course for today is musculoskeletal conditions. So we have two types of mechanism of injury. First, we have the contact, which is the one that will touch the body, and the other is the non-contact. So under the word contact, we have the extreme anterior force applied to the posterior tibia. So for example, this is your tibia, this is your femur, and this is your tibia. This is the anterior side, and this is the posterior side. So when it is hit from the back, and it will be pushed to the front, that is a this is what we call as an extreme anterior force applied to the proximal tibia of the flex. So it should be like this. So since we are visualizing this, so this is again the femur, this is the anterior side, this is the posterior side. So it is stated here that the knee should be flexed. So we will turn it this way, as you can see. And then your tibia here, and there is an anterior force applied, extreme anterior force. So if an anterior force hits the tibia, it will be moved posteriorly, like that. So that is one of the mechanism injuries. Then the next is the dashboard injury, wherein when you are riding a car and the car suddenly stops, your knee hits the dashboard or the front of the car. That's counted as a dashboard injury. Next, we have the secondary to falling to forward flex knee. So it is similar with the first one. And when the knee is flexed, then there is a high probability for PCL instability. And next, we have sports. Since these sports like football, skiing, soccer, and baseball have a lot of contact, like a lot of motion that is needed, especially with the legs, sudden stoppings, like sudden change in position, shifting from going forward to backwards. So that may be counted as a contact type of mechanism of injury for the PCL injury. So for the non-contact, we have the rotational hyperextension injury of the knee joint. Then next we have the hyperflexion or hyperextension. So next we have the epidemiology. So as you can see here, it is mostly common in motorists since, as I mentioned earlier, with the dashboard injury, it happens in the car. So we can conclude that MVA is one of the causes of PCL injury, as well as athletes, since, as I mentioned earlier, that it may happen in sports due to sudden changes in position of a player. And here we have a male to female ratio, wherein we have in every two males, there is only one female that this injury occurs. So the signs and symptoms, so we have the discomfort with the weight bearing in semi-flex position. So for example, again, this will be your knee. So you will be feeling a little bit of pain when it when you bend your knee in a flex position, like that. Then next we have the aching in the knee when walking in long distances. And next is the instability. Next is the retropatellar pain or and pain in the medial compartment of the knee. So as when we talk about retropatellar pain, so as we all know, when your femur and your tibia is positioned this way, there's also a bone here, and that bone is called the patella. So what this means is there is pain between the space here from the patella and the femur. So there may also be swelling and stiffness. And not only that, the patient may also feel a popping sensation during the accident. So we have here the grading for PCL injury. So in grade 1, we have the 1 to 5 millimeter posterior translation rather. So this is only minimal since it is only 1 to 5 millimeter. So grade 2, this is 6 to 10 millimeter. The difference here is there is a complete tear in the PCL without another injury. For the grade 3, it is more than 10 millimeter in posterior tibial translation, and this also has another injury. So the difference in the three, for grade 1, there it's only the posterior translation and no tear. Grade 2 has the translation and tear, and the grade 3 has the translation, the tear, and another injury. So here we have the PCL injuries, medical assessment, and treatment. So we can see here, the MRI is considered to be the gold standard for PCL injury diagnosis. So as you can see, it has 96 to 100% accuracy in detection of acute PCL injury, and it can determine the locations and severity of the injury. So as you can see here, for here, these are only the ancillary procedures. These are the most common, which is the MRI and the ultrasound. This is the most applicable for the patient with PCL injury. So we can safely say that CT scan is not that commonly used or not that very applicable for PCL injury. So we also have here ultrasound that can be used to evaluate the degree of instability. So now let's talk about the PCL reconstruction. So there are two types. So we have the single bundle technique and the double bundle technique. As you can see here in the picture, that in the single bundle technique, there is only one here that is used. And for the double, there is two. So the single bundle technique, the anatomical technique relies on radiographic and arthroscopic reference and is more preferred versus the isometric point technique, in which tends to result in laxity in post-operative period as time passes due to constraint of the joint. So we have the double bundle technique. So it just states here that should restore the normal knee kinematics in comparison with single bundle construction, which restores kinematics only between the first 0 degree to 60 degree of flexion. So by that, we can see the difference that the double bundle can restore the full flexion of the knee, while the single bundle doesn't. Only it only restores 0 degree to 60 degree of flexion. And then the double bundle can uses one tibial tunnel and two femoral tunnels, with the anterolateral bundle tunnel being the bigger than one for the posteromedial bundle. After which we have the graft fixation. So there are two types of graft fixation that can be used for PCL injury. So we have here the transtibial technique. Uh, it stimulates the origin, uh, simulates rather, the origins of the anterolateral medial bundle of both femur and tibia. So as you can see here, uh, it is placed inwards here, and for the other, like this as well. So this technique has biomechanical disadvantage, which is known as the killer turn, which is the sharp angle on the exit of the tibial tunnel, which can result in attenuation with the subsequent failure of graft. So as you can see here, if ever the knee bends, this can be impinged. As you can see, it has a probability to be impinged here. Then next, we have the tibial inlay technique. So the other one was transtibial technique, and this one is the tibial inlay technique. So it uses RF of bony avulsion and to secure bone-to-bone tibial attachment with an anchor or screw. So as you can see here, it's similar to the other one, but this one uses a screw for the for the tibia. So it has a disadvantage of having a screw fixation within 20 millimeter of the popliteal artery. So it can be risky since we are talking about a artery, so it may be hit or whatnot. It can be impinged. So this technique can be performed by a posterior medial approach between the semitendinosus and the medial gastrocnemius. And multiple arthroscopic techniques have been described. So that's all about PCL injury, and the rest I have given it in your handouts. So that's all. Thank you. Delete na ako. So, puts.